Hi, welcome to another episode. IronDPC.com, Stefan Hartman here. Today we're going to be going through part 3 of my lectures on testosterone, pharmaceutical methods of increasing testosterone in men. So we go to up to date, right? Because that's where everyone goes first in medicine. Up to date is an institution I'm rapidly losing faith in. If you look at the criteria for who benefits, who should be on testosterone therapy, they say there's strict criteria. You have to be hypogonadal, right? But I'm now in the anti-aging medicine sphere where I'm learning the benefits of testosterone therapy. I'm seeing applications towards a whole host of disease processes, not just hypogonadal men. And you can look at my other videos on that. So we compare up to date for hormone use in transgenders. And there's strict criteria on this. They're like, oh yeah, we have to, there's certain criteria here. Yes, hormone therapy for those who want transgenderism, yes, approved by up to date. But for men who want it for anti-aging purposes, no. So there you have it. If you go to mainstream medicine, this is what you're going to get. Most providers use up to date as a reference guide. So we're leaving up to date behind. We're going to be going into more anti-aging medicine literature here. So we'll start with the SERMs or AIs, so androgen inhibitors, basically, or selective estrogen receptor modulators. So estradiol, normally considered a female hormone, appears to play a significant role in men in a variety of physiologic functions, such as bone metabolism, cardiovascular health, testicular function. As such, estradiol has been targeted by male reproductive and sexual medicine specialists to help treat conditions such as infertility and hypogonadism. The compounds that modulate estradiol levels in these clinical conditions are referred to as SERMs and AIs. In a certain subset of infertile men, particularly those with hypogonadism, or those who have low serum testosterone to estradiol ratio, there is some evidence suggesting that SERMs and AIs can reverse the low serum testosterone levels or the testosterone-estradiol imbalance, and occasionally improve any associated infertility or subfertile states. They can also help men feel better by decreasing estradiol if it's too high, and by that purpose also increasing testosterone. Genova Diagnostics has some pretty phenomenal slides on here, so we're going to go through them a little bit. Aromatase, conversion of androstenedione to estrone, and conversion of testosterone to estradiol. What causes decreased aromatase activity? Well, they have a couple interesting ones here, a couple herbals, green tea extract, flaxseed, and then of course anastrozole, which is an aromatase inhibitor. What causes increased aromatase activity? Inflammation, excessive adipose, so fat, which we discussed in a previous lecture, high insulin, alcohol use, and mold and biotoxin illness. Mold is quite under-recognized as a pathological mechanism in a host of illnesses, including apparently low testosterone or high estradiol, which usually goes hand in hand. So what do aromatase inhibitors do? They're thought to inhibit the conversion of testosterone to estradiol, basically, estrogen. Estradiol is E3, peripherally inside adipocytes and also within the testes. AIs are drugs that lower estrogen levels by blocking the aromatase enzyme, the enzyme that converts testosterone to estradiol. AIs were initially used for the treatment of metastatic breast cancer. So if you Google that, that's what you're going to see. So don't be shocked. But they are used now to help men with low testosterone. They're used, I think it must be off-label, because I don't know if off-label for the purposes of anti-aging, but for men who have diagnostic criteria of hypogonadism, that's where AIs are used as well. Anastrozole is a selective nonsteroidal AI that is approved for the treatment of breast cancer and is used off-label to treat certain subset of infertile patients. There you have it. Letrozole is a more potent selective AI, and similar to anastrozole, has been used to treat those as well. They're both great ones. Just trying to figure out, the key is figuring out what dose works for the patient. So depending on how bad their levels are, we might start at a certain dose and then maybe back off on that over time as the patient improves. So one is looking at the levels, but two, it's also how does the patient feel? Do they feel better or do they feel worse? If it's worse, maybe we back off a little bit on the AI. Because men do need estradiol as well. There's a balance there. We don't want to crush it into oblivion. Excess body fat, we talked about that. We're not going to go over that again. I talked about that extensively in the previous lectures. Letrozole once weekly normalizes serum testosterone in obesity-related hypogonadism. So it's more potent than anastrozole. So in this study, it only needed to be taken once weekly. Let's see, what else do we have here? If my slides will move, yes. Aromatase inhibitors plus weight loss improves hormonal profile of obese hypogonadal men without causing major side effects. Side effects that I've noticed sometimes include hot flashes. So if that happens, we sometimes back off the dose a little bit. This was a randomized double-blind placebo-controlled pilot trial. There were 23 men, obese men, and they were randomized to weight loss, so diet and exercise, plus anastrozole at 1 milligram daily, or placebo. Placebo plus weight loss. For 6 months. Inclusion criteria: total testosterone less than 300, average of 2 measurements, estradiol greater than 10.9, symptoms of hypogonadism by questionnaire, muscle strength by bioindex diameter. Okay. Results after 6 months of therapy: androgen receptor plus weight loss group had higher testosterone and lower estradiol. Changes in symptoms and muscle strength did not differ between groups. Now why might that happen? I suspect because they weren't on a structured progressive resistance training program, and they were not given testosterone. So if you want to see bigger muscle mass and bigger strength gains, if the drug isn't going to do it for you, no, you still need to implement the iron. That's why I have the barbell in Iron Direct Primary Care's logo. The weightlifting is integral to getting your strength back and feeling back. I mean, you're not going to feel great lifting weights if you have low testosterone and high estrogen as a male. So, we need to fix the hormones first. But once we fix the hormones, then you're going to see the benefits in the gym, feel better, and want to go to the gym in the first place. Put some work in. And then the weight comes after that, right? The weight loss will come once you start feeling better. You're able to do the exercise again. Clomiphene, interesting drug here. Although clomiphene was initially and exclusively used in men with infertility, it has recently taken on a secondary role as a sole therapeutic option for men with hypogonadism. Several studies have evaluated clomiphene as a non-U.S. Food and Drug Administration alternative to exogenous testosterone therapy. And I know an endocrinologist who did this for a patient of mine when I worked in psychiatry. Sent him to the endocrine, and the guy put him on clomiphene and anastrozole. And sure enough, the patient's testosterone came up, started feeling a bit better. So cool little drug here. Let's see what else here. Tamoxifen. Tamoxifen citrate is another oral serum that was approved in the 70s for the treatment of breast cancer. It has tissue-specific action and acts as an estrogen receptor blocker in breast tissue and exhibits agonistic properties in the bone and uterus, in female patients, of course. So men who are on testosterone therapy exogenously, so bodybuilders, if they don't use in one of these sort of androgen receptor AIs or SERMs, they could develop man boobs, right? Because the breast tissue will grow. And so if you use these androgen receptor blocker, not androgen, AIs or SERMs, then the breast tissue is less likely to grow. And compounding pharmacies I've been speaking to can also do like a cream component of this, and you can just put it on the breast tissue as well, if that's all you want to focus on and you don't want some of the potential side effects of one of these AIs or SERMs. For the most part, though, they're pretty well tolerated if we just get the dose right. So clomiphene plus anastrozole, we just talked about that story. We'll look a little bit about this study if you're looking into 2. I wouldn't really do 2 to start with for a patient. I know that endocrine did it, but I think using 2 of these drugs can give patients some side effects. I prefer more testosterone, which is more natural, and then maybe one of the SERMs or AIs. Let's see, efficacy of anastrozole in the treatment of hypogonadism subfertile men with a body mass index greater than 25. Anastrozole improves hormonal profiles and semen parameters in hypogonadal subfertile men with body mass index greater than 25, and may aid in achieving pregnancy, especially in conjunction with assisted reproductive techniques. So, a lot of men do have problems with, subfertility, erectile problems, low semen counts, and it's a huge problem, and it's related to low testosterone and higher estradiol. More on up to date. What did they say here? I'm going to ignore up to date. I don't even know why I have this slide here. Issues with current TRT. So we're going to talk a little bit about issues with TRT. So let's get into that. So oral testosterone, poorly absorbed with GI side effects. So natural T is rapidly inactivated by first pass hepatic metabolism, making oral therapy absolutely garbage. I don't do that. I don't think anyone in the anti-aging sphere does oral testosterone. We're going to skip that. Buccal testosterone, better than tablets, but may have some irritation. So these are lozenges, sublingual ones. I know a couple compounding pharmacies make these. And they can work pretty well. And if you don't get irritation with them on the gums, then they can work for patients. It avoids first pass metabolism because it goes through the mucosa. So that's definitely an option for some patients. Let's see, what else do we have here? Nasal testosterone. Yep. There's a couple generic brands. You can get them at like Walgreens, CVS even. And then obviously compounders. I've seen one compounder had an interesting like spray one. You can spray it up the nose. There's gels that you can put inside the nose. These are pretty great. I like them. Just depends on what you're interested in. Obviously the benefit would be you're not going to, accidentally rub the cat with your testosterone. It's going to be in your nose. Maybe you could get some nasal irritation. Maybe blowing your nose might be an issue. You'd lose it. You'd waste your testosterone if you're blowing your nose. You have a runny nose that week. It's just trial and error for most patients, see what they like best. Let's go on to some other options here. Subdermal testosterone implants. This is probably the most popular form in anti-aging medicine that I've seen. This is basically pellet therapy, where we ask the compounding pharmacy to make these little BBs, and then we use a trocar. We make a little incision, and typically it's the buttock, and then we insert these pellets into the patient. And really well tolerated, ease of use, right? Because you don't need to do like a testosterone injection or a nasal spray every day. You do it and you forget about it. Sure, there is risk with it, any intervention, infection, so forth, but you do sterile precautions, that's minimized. One of the biggest ones I've heard about is rejection of the pellets. And rejection is where your body wants to push them out for some reason or another. I talked to this one expert who, I talked to him on the flight over to Las Vegas to the anti-aging conference, and he said patients who got the jab, they started rejecting the pellets. And it was such a big issue that they said, we're not going to do pellets for anyone who recently got the jab. Because for some reason the body would be hyperactive, would have a hyperactive immune response to these, get all irritated, and you'd have to take them out. So there's that. Very interesting. Transdermal testosterone and testosterone patches. Yeah, these are other options out there. They're available commercially as well as with a compounding pharmacy. Basically, you can put them on different areas. You always rotate these areas. Maybe you'll put them on the axilla. Maybe you put them on the shoulder. I know some creams you can even put them on the testicle area. The obvious limitation with this would be transfer to someone else. Like obviously you wouldn't want to get testosterone to your wife. So there's the person-to-person transmission with that possibly. And it's pretty well absorbed too. This is the transdermal one is probably one of the better ones to be absorbed. Testosterone in gel liquid solutions. Yep. Well-known version of testosterone. They've been used since the 1950s. So let's see what anything. Oh yeah, the one thing I wanted to mention was that they have grapeseed and cottonseed oil for these injections. So I'm a huge proponent here of iron deficiency species of avoiding grapeseed and cottonseed oils. I tell my patients to avoid them at all costs. And then here we have the best mechanism for delivery of testosterone as far as injectables go. It's always in a solution of grapeseed and cottonseed oil. So, maybe that can give some problems to some people. I have a belief that these things are quite inflammatory, and that may be a reason why some men on testosterone injections get acne. And so, I think maybe it's not from the testosterone itself, but maybe from these inflammatory seed oils. That's a theory that I have. Can't prove it, but I mean, if other options don't appeal to you and you'd rather just do the injections, sure, let's do it. Let's see how you react. Maybe you feel just fine on it. Maybe you don't get acne, but if you're starting to get acne, maybe you're not feeling too great on it, maybe some more inflammation, I think it would be the seed oils. So where does it go? Testosterone. If you choose this option, you're gonna be injecting it yourself. I'm not gonna be there to inject it for you. You're gonna be putting it right there, as the diagram shows. We like to spread it out over the week with most, and we're gonna get into the different formulations of testosterone. But for the most part, you're gonna be doing it 2 or 3 times a week. The problem with injecting it maybe just once or twice a week is that you can get super physiologic levels in a very short range. So your testosterone will go super high, and then it'll drop off. And we don't want those fluctuations. We want a more natural testosterone level, how it would occur normally in the body. So if you're doing a nasal or a transdermal or the pellet, it releases slowly into the body, and so you don't get the spikes and valleys associated with some forms of testosterone. We're talking about testosterone propionate specifically here. So specifically, testosterone propionate gets super physiologic. And what do we have here? Testosterone cypionate. So one of the more common versions of testosterone. It's a bit better. The fluctuation in serum T levels can result in mood swings and changes in libido. Yeah. But this is probably the most common form. So what we would do with this, if we did this way, is we would want to split it up over the week. Maybe 2 or 3 injections per week. Testosterone enanthate. This is available in sesame oil. Okay. So the recommended starting dose with testosterone enanthate is the same as testosterone cypionate in all guidelines. The effective varying dose of TE on serum T was evaluated in 23 males. Very good. A little bit of research here. Erythrocytosis. Yeah, so more red blood cells. That can be one side effect. And obviously we'd be monitoring blood when we're doing this. Testosterone undecanate. Very interesting drug here. Long-acting testosterone injection. So you don't need to inject it so much. So what do they do here? Yeah. So the biggest thing about this is that there's like kind of a black box warning on them nowadays. It's available in the brand of Veed. You can look it up there following the link if you follow the PowerPoint here. You have to be monitored with a medical professional when you get this injection. You need to have an EpiPen ready as well, because you can get a serious allergic reaction, and you can get rarely an emboli, which is not a blood clot, but a different emboli from the injection of the decanate. So there's a small risk of that. But the benefit is there's fewer injections. I think they did it every couple months. Is that what they did here? Yeah. So that's the benefit of that. You can get away with about 10-week intervals of injections. Let's see. So testosterone esters, such as testosterone enanthate or cypionate injections, are widely used in the United States and throughout the world. The recommended starting dose is 150 to 200 milligrams, administered intramuscularly once every 2 to 3 weeks. More recent studies show that these medium long-acting testosterone esters can be administered by subcutaneous injection weekly, producing more stable testosterone levels compared to intramuscular injections testosterone decanate injections, 750 milligrams administered every 10 weeks apart, or 1,000 milligrams every 12 weeks, are the preferred testosterone replacement therapy in many parts of the world, but not in the United States because of the regulatory requirement of an observation period for about 30 minutes after injection for cough episodes. T-ester mixtures have been widely used for substitution therapy of male hypogonadism, with the idea that a short-acting tester is effective for substitution during the first days of treatment, while a longer-acting T, enanthate, allows for an effective substitution for the end of injection interval. However, the pharmacokinetic parameters of the individual T esters show that both preparations cause the highest T serum concentrations shortly after injection. The addition of testosterone propionate and testosterone ester only increases the initial undesired T peak, producing a much wider fluctuation in T serum concentrations relative to injection of TE alone. For the treatment of male hypogonadism, there is no advantage in combining the available short and long-acting T esters. Alright, we gotta choose one then. Measure pregnenolone. Yes, I do that on occasion. Cholesterol and pregnenolone. Cholesterol is the building block of all steroid hormones. You need healthy fats and adequate cholesterol levels to make hormones. Very low cholesterol levels contribute to poor hormone productions. Statins. Red yeast rice. Binders. And genetically low cholesterol. Associated with increased risk of cancer, suicide, cancer, memory problems. We need cholesterol. I talk about that all the time here on this channel. Don't know why my colleagues are so focused on reducing cholesterol. Pregnenolone. Manufactured primarily in the adrenal glands, nearly all other steroid hormones are made from this precursor. In times of chronic adrenal stress, levels drop. Aging leads to a decrease, a biomarker of aging. Enhances memory and reduces stress-induced fatigue. So I measure pregnenolone in my aging patients. I think it is quite helpful. And compounding pharmacists can add a pregnenolone to the cream as well, if we're doing a cream form of testosterone or for females, estrogen replacement. Monitoring. So after initiation of TRT, patients are evaluated to assess symptomatic improvement, presence of adverse effects, and compliance with treatment. The time course of the effects induced by TRT has been reviewed, demonstrating an improved sexual desire appearing after 3 weeks, reaching a plateau at 6 weeks. Improved erectile function and ejaculation may require up to 6 months. The improved depressive mood may appear within 3 to 6 weeks, with a maximum after 18 to 30 weeks. Failure to benefit within a reasonable time frame of 6 months for sexual symptoms associated with restoration of normal T levels should prompt versus a critical risk versus benefit estimation on whether to continue. Alternatively, it is recommended treatment with a PDE5 inhibitor in men with persistent erectile dysfunction who were adequately treated TRT. So that's your sildenafil, rather than no further treatment. At the same time, patients with unexplained anemia who improve on TRT, or men with low vertebral or femoral bone mineral density, continuation can be considered even in the absence of another symptom improvement. So this is still focusing on the kind of conventional reason for testosterone replacement therapy, and we use that as well. So let's just be mindful of what they're saying here. The risks of this treatment are still poorly defined, as well as the long-term efficacy of T. So we should probably make another video on the risks of testosterone therapy, and because there's a lot of misinformation out there. If you talk to your regular doctor, they're going to say testosterone is going to give you a heart attack, or testosterone is going to give you prostate cancer. It's horseshit. That's what it is. It doesn't do that. It's actually inverse is true. Men with low testosterone are more likely to get a heart attack. Okay? So there's a lot of misinformation out there. I wouldn't Google this stuff. You just get the wrong idea and you'll get anxious about it. Testosterone done right is safe. And we're not talking about bodybuilders at the super physiologic level. That's a whole nother story. We're talking about getting men back their strength, getting back men their testosterone, their libido, their how they even feel about themselves. Not just improving like your mental state, but just how you feel about yourself. That's what matters here. And yeah, it does decrease your risk of having a heart attack, right? If your testosterone is low, you are at increased risk of having a heart attack. We're going to improve that testosterone, and that's not conventional. The conventional modality is they don't even check testosterone, they don't even check estradiol. They just see that your cholesterol is high and they put you on a pill to lower your cholesterol. And they say that's going to improve your risk of having a heart attack. And that's completely false. And you can look at my videos on that here, where we look at lipidology and understanding cholesterol and understanding what causes a heart attack in the first place. Right? It's not just lowering cholesterol. And that's probably a byproduct of statin therapy. Statin therapy reduces inflammation. And that inflammatory part is probably why some studies show that these statin drugs work. And as a side effect, it lowers cholesterol. I don't see lowering cholesterol as a benefit. I see it as a side effect of the medication. And by proxy, we're seeing positive effect in some studies with statin drugs. And the statin drugs, don't give me, I'm getting into statin drugs. This video is about testosterone, the methods of pharmaceutical interventions for testosterone. Now we have our AIs and our SERMs. So if we see a man with high estradiol, we want to look at those. Most likely, if they have high estradiol, they're going to have low T. So we want to improve the T. We may do some testosterone, right? Combined with everything else we're doing, you can see my videos on natural ways to improve testosterone. But a combination of the two, estradiol blockers and testosterone boosting medicines, that is the goal here. I hope you all enjoyed this lecture. You can, again, look at any of these studies that I linked to here. I recommend you do your own research on which one interests you, whether that's pellet therapy or testosterone injections, or maybe you just want to start with maybe a gel for the nose, or maybe a cream or a patch. You just want to start there and see how you feel. Sure, that's easy. We can start that. That's it for today. See y'all next time.